Hello, everyone. Welcome to our very first Care Connection webinar of 2022. I am so thrilled to be here with you all today. My name is Laurel Gumpert, and I'm the Educational Program Coordinator here at the Alzheimer's Foundation of America. This year, we have an incredible lineup of speakers for our Care Connections webinar series, and today is certainly no exception. Joining me, I have Dr. Gregory Hinrichsen, who will be presenting on depression in older adults with cognitive impairment. So just some brief housekeeping before we get started. All lines are currently muted. However, we really do encourage questions. So on the right-hand side of your screen, you should see a little box that says questions. So after the presentation, we're going to have time for a brief Q&A. So I highly encourage you all to take advantage of this opportunity and ask any questions that you may have. So now I am very pleased to introduce Dr. Gregory Hinrichsen, Associate Clinical Professor in the Department of Geriatric and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. During over 40 years in the field of psychology and aging, Greg Hinrichsen has provided clinical services, conducted research, directed psychology internships and fellowship programs. He's contributed to public policy and had a variety of leadership roles in professional organizations. He is also the author of Assessment and Treatment of Older Adults, a guide for mental health professionals. So we are very lucky to have him speaking with us today. I have been so excited for this presentation, so I hope you all are as excited as me to go through all this really valuable information. So without further ado, I pass it on to you, Dr. Hinrichsen.
Okay, well, good to be here. I have been in the aging field since I was 25 years old, and now I'm 70. And so I have certainly had an opportunity to talk with a lot of older people during the course of my career, including older people who've had depression and older people who've had cognitive impairment and individuals who have had both of those. And I think that for people who have cognitive impairment, which includes dementia, which we'll talk a bit about that, it can be particularly challenging. And I remember when I was a psychology intern and I started working with people with cognitive impairment, and I asked the psychiatrist I was working with, what's it like for people who have cognitive impairment? What is their experience of it? And I remember her saying, well, we don't really know. Because it may be hard for people to explain what it's like to have cognitive impairment. And I remember shortly thereafter, I had a dream in which I dreamt I had cognitive impairment, I guess in an effort to try to get some experience of it. And I remember in my dream, I had the feeling of being confused and being lonely. And I think that although these days there are first-person accounts of people who have cognitive impairment, it can be very challenging for people as well as those around them who are providing help. So could we go to the next slide, please? Okay. I work at Mount Sinai Medical School in the Geriatrics department, and we have been doing programming for the last 5 or 6 years with one of our community programs, and it's been supported by the UJA Federation. And so we wanted to acknowledge them for their support of that effort. Next slide. So the first question is, what is depression? And there are lots of different meanings of depression, and I think it can lend itself to confusion because there's, among other things, the everyday meaning of depression. Have you heard people say, because of COVID, I'm feeling so depressed? Well, that may reflect the fact that on a given day, they're feeling distressed or unhappy, or something has gone on during the day that affects the mood, as it does with everybody. So for all of us, we have good days and we have not such good days, and partly they're reflected in what our particular mood is that day. So there's the everyday meaning of depression. And then we began to think about what mental health people would think about depression, which is more than every day. And in the mental health profession, sometimes there's reference to what are called clinically elevated symptoms of depression. What does that mean? People are having more than usual feelings of depression or related things. They tend to be more intense and more frequent. And they become of concern is because if you have elevated symptoms of depression, you're at more risk of getting a clinical syndrome of depression. And we know that probably 15% of adults, as well as older adults, have higher levels of depression, clinically elevated depression. We also know that during the COVID pandemic, which has been so stressful to so many of us, that these rates of not only clinically elevated symptoms of depression, but also elevated symptoms of anxiety are twice of what they normally are. So it reflects the fact that we're all sensitive creatures to what's going on around us, and that we're feeling the emotional effects of that. What are sometimes called clinical syndromes of depression are outlined in the psychiatric manual called the Diagnostic and Statistical Manual of Mental Disorders, which some of you may be familiar with, which outlines what are seen as mental health problems that have a name and have certain criteria. So a clinically significant syndrome is even more intense and long-standing symptoms of depression that you find in the elevated symptoms of depression, and they affect your ability to function. It's much harder to function. It affects the way you think, which is usually negatively. Also, people may have problems with concentration because of the depression. It can affect sleep and appetite and other kinds of things. And we call it a major depression. And we know that in the general population of older adults, people living in the community, about 3 to 4% of people living in the community, older adults, have a major depression, which sometimes people find surprising because there's a general assumption that depression is common among older adults, and it's not. And in fact, rates of serious depression, which we call major depression in older adults, are half those that than compared to younger adults. So you can see there's sort of a continuum of here when we think about depression, from every day to things are more is going on than that, to what we call a syndrome. So major depression is the more severe kind of depression. Next slide. So what is cognitive impairment? Well, it's sort of on a continuum as well. We know that as people get older, there are changes in their mental abilities. Even starting in late 20s, people, if you do studies, you find that people find it increasingly, it takes longer to learn new information and to process new information. And there are psychologists who have studied this. And the bottom line is, our brain, which is part of our body, ages. And so evidence of that is usually it's slower to learn new information, and it's harder to process it. Sometimes that gets mistaken for the idea that people can't learn new information. In fact, we know that most older adults can, it just takes longer. And also we know that as people get older, they may not want to learn certain new information, but would rather learn other new information. So in some ways, given that it's harder to learn new things, people choose about what they're going to learn or not learn. Some older people are on top of the latest developments in computers. Others are not because they don't care so much about it. And if they wanted to do it, they could do it, but they know it's going to take a lot of effort. So they're normal kinds of changes. I kind of think of it as, if you think of the brain as hardware, people continue to update their software, which is the kind of experiences that people have. So they're changes, and for most people, they don't have a big impact on them. Another piece of this is what is sometimes called mild cognitive impairment, or sometimes called mild neurocognitive disorder. And that's more than usual changes in mental abilities. So if we know what's the average, what's the usual for older people, these are more than average and more than usual. And it's called mild cognitive impairment. I hasten to add that even among older adults who have normal age-related changes, there's considerable variability. So we're just talking about averages. So people with mild cognitive impairment have more than average, but usually it doesn't affect people's ability to get the things done that they want to get done. Then there is what is called dementia, which it is also called major neurocognitive disorder, but most people refer to it as dementia. Dementia is a progressive decline in mental abilities, a progressive decline. So that means that things usually get worse. And there are different kinds of dementia. Now, most people know the term Alzheimer's disease, which is one type of dementia and the most common type. But there are other types too. There's something called Lewy body dementia, which vascular dementia, which means that there are, for example, many little small strokes, small damages that are being done to the brain because of the vascular system, and something called frontal temporal dementia. Most people generally refer to dementia as Alzheimer's disease, but to put a technical point on it, Alzheimer's disease is only one type of dementia, albeit the most common type. So you can see there's normal, and what can be a challenge is that people may misinterpret what may be normal age-related changes for something that's more severe than that. So it's very helpful if someone comes in and complains that they're having problems with their memory or things, is to first of all know what's the usual, and then what is unusual and what may be maybe on the more extreme end, which may be that it's a progressive kind of dementia, such as Alzheimer's disease. So next slide. So we'll talk about people with dementia, and the question is, do people with dementia get depressed? And yes, they can. Not all, but it's not that uncommon. And how common is it? Well, there are different studies that have done. And so the one studies suggest 30 to 50% of people with dementia have depression. And the reason there's a range here is because depression may be defined differently or assessed differently, but it's fairly common. If you remember that the more severe kind of depression is relatively uncommon in older adults, these are much higher rates. Well, why would that be? Why would people who have dementia become depressed? And so there are a number of possible reasons. One thought is that depression in and of itself can increase risk for dementia. Why would that be? People who may be severely depressed for an extended period of time, that may not be good for their brains and may increase risk for having cognitive impairment, such as dementia. Another thought is if you see somebody with dementia and they're depressed, the depression may be a result of brain changes associated with dementia. So dementia is essentially damage to the brain, the causes of which are sometimes understood, but still there are many mysteries to it. And if the things that are involved in our mental thinking processes are impaired, they may also be impaired in those processes in our brain which regulate our emotions. So it may be that there's a biological reason for the depression you see in dementia as one of the secondary things that you see from that. Then there's the thinking is, well, depression can be a reaction to dealing with dementia. That is, for individuals who reckon with the fact that they are not thinking as clearly as before, and they may become depressed because of that. And among older adults, I often hear from people, the last thing I want when I get old is to get dementia. So among some people, they do get dementia, and among some people, they may be very distressed that they have dementia, and as a result, get depressed. I might mention in the work that I do as a psychologist, I sometimes work with older people who are depressed and have dementia, and I work with them around coming to terms with the reality that they have this, and then figuring out how they can maximize the quality of life as much as possible, even if they do have dementia. Another thought is depression among people with cognitive problem may be a reaction to the fact that they're doing fewer things that used to do that brought them pleasure and meaning and well-being. That is, what's happened is they've gotten cut off from things that are important to them, as many things are important to us. If you just think about how the COVID pandemic has reduced the number of things that we're able to do, things we like to do, be with our family, be with our friends, go out, have a meal, take a walk, go to a museum, or whatever you do that brings you joy. Without that increases the likelihood that we're going to feel more depressed, because we don't have those things that make us feel better. And it may depend upon the particular person why a person with dementia has depression, but it may be a combination of different things, or it may depend upon that individual. So how do mental health professionals determine whether someone is depressed or not? Well, in general, what you do is you ask the person and ask them to report what their experience has been. And on the basis of that, you can get a better idea of what kind of depression they have and how severe it might be. Or you can observe that the person is showing signs of depression. For example, I work with geriatricians who are medical doctors who specialize in aging, who sometimes have long-standing relationships with their patients, and I'll get a referral. They'll say, I've known this patient for a long time, and she's always been pretty upbeat, and there's something going on because she just seems sad and she doesn't seem optimistic in the way, and I think something's happening. Would you evaluate her to see if she has depression? And if so, work with her for a while to help improve that. Often the people around us have a pretty good gauge about what our baseline is in terms of what we do and how we are feeling. And family and friends can sometimes be a good source of information about whether a person is depressed or not. So sometimes a family member would say to me, my mom was always a very upbeat person, but she isn't now, and there's something going on here. So those are sources of information that can be used to assess depression. Next slide. Next slide. Okay, so here is a screening questionnaire for depression. It's called the Geriatric Depression Rating Scale, it's widely used. It's been around for almost 40 years, and you can see some of the questions that you ask people. They're yes or no questions, and here I indicate what's after the question is. If you answered it that way, it would indicate that you're more likely to depress. So you can see these things. Are you basically satisfied with your life or not? Have you dropped things that interests you did? Does your life feel empty? Are you in good spirits? Are you afraid that something bad is going to happen? Do you feel helpless, worthless? Do you feel full of energy? So you can see these kinds of questions can get at more psychological aspects of depression, and can give you an idea. Now, the practical problem, if somebody has dementia or cognitive impairment, it may be more difficult for people to answer these kinds of questions. All right, next slide. Okay, so there are people who have developed alternative ways of trying to determine whether a person with dementia has depression. Since some people may not be able to tell you or report on what their experience has been, then there are ways of trying to observe them. And so there's something called the Cornell scale for depression and dementia, in which doctors and family members can provide reports on changes that would be consistent with having usually a more severe depression. So what are the things you might observe? Somebody is worrying and anxious. If you look at them, they seem sad, and there's changes in their voice that would be consistent with feeling depressed. Something good happens, but they don't react in a way that we normally do. There can be increased irritability on the person's part. Sometimes people who are depressed are irritable. There are behavioral changes. There can be a slowing in their reactions or their speech. Loss of interest in things, restlessness. There can be physical changes, sleep and appetite changes, weight changes, fatigue. So you can see that depression has a lot of different aspects to it, particularly what we call a major depression. It affects the way you feel, it affects the way you act, it affects you physically, and all of these things can then help us better understand whether the person with dementia is depressed. Next slide. Okay, and here's another one, and changes in outlook. So the way you look at things. So even if you've got cognitive problems, people are able to generally communicate how they're looking at things, and see these are some of the negative ones that you can see that would be more. You don't have to have all these things, but if you have enough of them, they would suggest that you have, in our language, a major depression. Next slide. Okay, so here's a way to think about things, and they include thoughts, feelings, behavior, and I think the next slide shows the next piece of this, the body. Okay, so why am I presenting this? There's an approach to working with people who are depressed called cognitive behavioral therapy. And it basically says that the way we feel is affected by the way we think, and the way we feel can affect the way we behave, and these things can also affect our body. So as you may recall, when I showed you those prior slides, you saw things that were characteristic of depression, which was negative thoughts, feeling depressed, not doing as much, and maybe having seeing changes in your body in terms of sleep or appetite kinds of changes, or slowing down. So all of these things are connected with each other, And in the end, we're interested in what you can do to improve them. So for example, in cognitive behavioral therapy, you will work with people to help them to understand what they're thinking, how they're thinking, which is usually negative, and then help people to look at things differently. Or have people engage in more pleasant activities in an effort to improve their mood. All right. Or you may give the person an antidepressant medication, which acts through their body, which then can have effects in terms of improving their depression. Next slide. Okay. And what I want to emphasize here is if people have cognitive impairment, they may not be able to think clearly or have a good sense of what they are thinking. So from this approach, you probably have one less thing you have to work with here, which is working with people's thoughts. And often in terms of depression, you're working with people's behavior, and also sometimes for people who are depressed and have dementia, you may give them an antidepressant medication. Next slide. Okay, so sometimes there's a discussion about the downward spiral of depression, which is you feel worse, you do less. Then if you do less, you feel more tired. You then are maybe prone to criticize yourself for what's happening to me, feel even worse, and do even less. So you see this regardless of whether the issue is if a person has cognitive impairment or not, but it all takes on a life of its own, okay? So the practical problem is, what do you do to try to improve this? Next slide. So there are people who have worked with individuals who have dementia and are depressed and their family members. And the person who's done the most interesting work around there is a psychologist named Linda Terry. And they have done a variety of studies that are very practical and have found to be useful. And what they found is that using behavioral approaches with people who have dementia and their family members decrease depression. Remember, if a person has cognitive problems, they probably are not in a position to be engaged in looking at their thinking processes. So what is Dr. Terry and her colleagues? So they did studies in which they got a group of people with dementia who had depression and their family members. And what did they do to try to improve this situation? Dr. Terry helped caregivers of people with depression to identify pleasant events that they could increase the number of for the person with dementia. They help the family member, the caregiver, to better handle the problems that may come up with a person with dementia. And so it's not uncommon if people have dementia, they have a variety of problems that change over time, which can be very stressful for the family member, the caregiver, and also for the person who has dementia. So what Dr. Terry did is increase the number of pleasant events that the person who had dementia engaged in, and give the family members a better handle on how to handle these. And what they found in this and other studies is that teaching these behavioral approaches, as well as helping the family members, were as effective as antidepressant medication without the potential side effects of them. And she also found that although the goal here was to decrease depression in people with dementia, she also found the family members themselves were less depressed and were less distressed, because they could see usually the improvement in the family member with dementia, and also probably felt more capable in handling things. Next slide. Okay. So what are better ways of managing behavioral problems? What are the kind of problems you sometimes see with people with dementia? What is sometimes called verbal agitation, repeated questioning or crying out. What is sometimes called physically non-aggressive behaviors, wandering, restless, pacing, stealing can sometimes happen. Verbally or physically aggressive behavior, shouting, hitting, even hurting oneself. So those can be very challenging things. And what Dr. Terry and her colleagues have done with family members is teach them what they call the ABCs of dementia caregiving. ABC as in what seems to be the activator of the problem. How did you respond to it? And what consequence did that response have? Sometimes people think that if a family member is having some of the one or more of these problems, that it's not clear where they come from. And sometimes it's not. But sometimes there are triggers to problem behaviors. And so part of this is teaching the family member to begin to be more careful observer of what may trigger it, and help people to respond in ways that are more likely to decrease the problem than increase them. And so essentially you are sort of teaching the family member to be a little bit of a behavioral psychologist. And there are studies that have been done here and elsewhere that found once you get family members as well as staff working in nursing homes or similar settings to better handle this, you have an improvement in the problem behavior. And I hasten to add that a certain amount of this is trial and error. And I'm almost always humble when I think about, the problems that family members may be contending with if someone has a dementia. But there are better ways of approaching it. And this particular approach has been found to be helpful in terms of reducing those behaviors, but also improving the emotional well-being of the family member and the person with dementia. Next slide. So what are some of the pleasant events that Dr. Terry would work with a family member to increase for the depressed person with dementia? Here are just some of the examples. And so the principle is do more things that are enjoyable, feel less depressed. So what some of the examples are, just taking a walk outside, which of course during these COVID, this terrible 2 years of COVID, even at the beginning was reluctant. Meeting with friends, listening to music, watching TV, laughing together, being with an animal, having a simple snack. Now, some of these things seem very small, but they can have meaningful effects for people. What are some other examples? Next slide. Helping out. I have a friend whose mother I know for many years. She, at the end of her life, had dementia. And I remember her daughter said, Mom always liked helping out. So she'd said, Mom, would you like to fold the laundry? Her mother was happy to do that, and her mother would do that, and sometimes the daughter would go and unfold the laundry so that her mother could do some more folding, and her mother felt better about that, or even helping out to a simple task like setting the table, being with other people, going on an outing, doing some crafts that a person is able to do. You see other examples here. Now, I hasten to add that with this COVID situation, it's been really hard for people to do things. And I think that a major challenge for people who are providing care to someone with dementia has been doing some of the normal things that you could. And so I think it's made the situation much more complicated for family members and people with dementia. But in principle, we find that doing more things that have the potential to increase emotional well-being, that they can make a meaningful difference. Next slide. All right, here's some more. Music for some people can be especially helpful. And it's notable that sometimes people may have some significant cognitive impairment, not remember things, but once you play music, they remember the song and can even sing to the music in a way that may bring pleasure. Next slide. So in the end, I talked about the downward spiral. The upward spiral in terms of improving depression is, if you do more, you feel less depressed. And if you feel less depressed, you may feel more hopeful, have more energy, and want to do more. And so, again, the principle here is that there are things that can be done to help somebody who has dementia or other kinds of cognitive impairment to improve their mood. It sometimes is trial and error. Sometimes they may seem like very small things you're doing, but sometimes those small things can make a difference. So I think that's the last slide. Oh, here, just this is the last. So here, another thing can help is to improve communication with a person with dementia. It can be very frustrating. So, here are some general recommendations. Have a one-on-one conversation that's not too complicated. Speak slowly and clearly. Give the person plenty of time to respond rather than sort of jumping in and trying to respond for them. Ask one question at a time, and try to basically simplify things so that communication is less complicated, less frustrating, and can create the feeling of connection that may not happen if you're less patient or less cognizant of the fact that communication needs to be made simpler. Okay, so I think at this point, I'm happy to take questions or comments.
Yes, well, first off, I just want to thank you so much for this presentation. I know I can speak for many of us that was all just so valuable. And to the people who have been asking questions, thank you so much. We're going to get to them now. And please keep asking questions. Sorry, okay, here we go. So this person mentioned that they never talked about vascular dementia with their mother who has it. She knows her memory is suspect, and her geriatric psychiatrist has not told her has told her her diagnosis, but
Yeah.
she's not sure that she understands. In addition, she's on antidepressants. This person's question is, should we talk to her about her condition? And is there a benefit to acknowledging and accepting her diagnosis?
That's such a good question.
Mm-hmm.
That's such a good question.
I know.
It's such a good question, and I don't think that the mental health field has done a very good job about thinking about that. And I was reading recently that half of people who have dementia and their family members don't even know, have not been told, or they don't remember, or they were told but weren't told in a way that could be understood, or were told and didn't want to hear it. So there's not a lot of good discussion about this. And I believe the Alzheimer's Association has a pamphlet, or they did something like something how to talk with people about the fact that they have cognitive impairment. And so the practical issue is depending upon the nature of the cognitive impairment, the person may not have the wherewithal to understand what's being said, but they might.
Mm-hmm.
And so for me, who are sometimes referred patients who have dementia or serious cognitive impairment, it's often left to me to try to explain it, because either it wasn't explained to them or wasn't explained in a way. So I usually start out by talking to the person about the fact that they have memory impairment. Now, I use that only because that's less dramatic and less frightening. And I think most people could say, well, my memory ain't as good as it used to be. And so I may use that as the foundation of saying, have you noticed any changes?
Mm-hmm.
in your memory or things like that. And not uncommonly, people will acknowledge that. Some people are in total denial, but I don't even know if that's the right word. Some people just may not even realize they have problems in terms of their mental functioning. And so for me, if I'm working with somebody who's distressed about that or other things, I try to slowly introduce the topic, figure out what they understand, what they've absorbed, and then see how far I can go in the conversation with them. And it may take a while. And so I might at some point say, yes, you have more than what we would expect at your age in terms of your memory problems here. And then I said, what do you understand what's going on, right? And somebody might say, do I have Alzheimer's disease? And depending upon the person, I might say, yes, you do have Alzheimer's disease. That's what the doctors have diagnosed. How do you feel about that? Oh, yeah. And so what I try to do, because for some people, the worst thing they can have is Alzheimer's disease. So what do you do with that? One, I think you can have an honest conversation about it. Because sometimes, that lonely and isolated feeling I had in my dream, sometimes people feel lonely and isolated because people are not talking to them about what's going on in which they realize on some level. So it can, in the end, it can be reassuring that somebody's going to talk with them about it rather than sort of whispering it behind their back. So I gauge what the person seems capable of handling and what they would like to talk about. So it depends upon the person. But usually I try to lay the groundwork for something that's positive. Look, you've got this. This is very distressing to you. I understand why it would be. Let's figure out how we can work together and figure out how you can make things the best they can given this situation.
Absolutely, yeah.
So anyway, that's my thought about it. Thank you for such a good question.
Yes, definitely. We also have another question. Could excessive playing of the lottery by a depressed person with moderate to severe Alzheimer's be one of the dangerous behaviors that you spoke about? This person mentions that her father is obsessed to the point of that if they don't take him to get scratch-off tickets every day, he constantly touches the tickets, counts his winnings aloud, shuffles the tickets, etc. And it's the only thing that he's interested in other than his pets. He does not want to help with other things. So perhaps some advice with this as well.
Well, I don't know. I guess first question is, has gambling been a problem for that person prior to in the past? And I guess you'd have to figure that out. And then I'm thinking like, well, I don't know if this gives pleasure, is it something that creates problems? I don't know. I mean, if we're talking about $1 lottery tickets, maybe that would be something that that would bring the person pleasure. So I guess it would just, to what extent is it a problem or not? And I guess if somebody was buying $500 lottery tickets every day, that potentially could be a problem.
Yes, definitely. Okay, I have another question. I think this will be really meaningful. What do you say to a person with dementia when this person says they want to die?
Well, that would probably, in my mind, mean they're feeling depressed. If somebody is now, people, I hear people say, "Well, if you had dementia, wouldn't you want to die?" As if that would be a rationale for somebody ending their life. You hear this sometimes about older adults, like, I get to that age, just kill me. You hear people say that. And from my point of view, that's really an ageist kind of remark. That is, it's. Can you imagine if you had a child with pediatric cancer and you said that it's better if that kid died? People would be horrified.
Yeah.
Right. And so why would it be acceptable? So if somebody was saying that to me, I would be thinking like, okay, I think it's time for a depression evaluation. Right. We can have we can have a philosophical discussion about whether under what circumstances life is worth living. But I'll tell you, I have talked with a lot of people over the years, and people living under extraordinarily difficult circumstances want to continue to live.
Mm-hmm.
And I think people are by nature resilient.
Mm-hmm.
And I think we have to be careful about falling prey to our own reaction to, oh my God, what was it like if I had that?
Mm-hmm.
In the end, my attitude is there are always options. You know, there are always options to deal with things, and you need to be careful about falling prey to your own reactions. Like, oh my God, I hope that doesn't happen to me.
Mm-hmm.
You know. So yes, if I had a family member saying that, I'd want to find out more what's going on and see if there's something that could be done to help them to have an improved quality of life and decrease depression.
Yeah, definitely. Checking in with ourselves in that moment as well, I think is really, really great advice. I do have someone who mentioned that they are a young therapist. How, when they're working with older adults, what is some advice that they can have to help meet them where they are?
Some advice for the therapist about how to better meet older adults where they are?
Correct.
I think it's the larger question about any of us in the healthcare field about meeting patients or clients where they are, regardless of what their differences may be. You know, the whole idea of multicultural awareness. If you're working with a population from a particular country or a language group or a socioeconomic background, it behooves us to try to understand what those circumstances are. And the same thing is with older adults. I would just say, if you're a younger therapist working with older adults, you have to be aware of the likelihood that you possess negative stereotypes about older adults that you may not be even aware of. You know, and the assumption that late life is a time of a terrible time, which you hear people say. I'm just telling you, after 40 years in the aging field, old age has its downsides. But so does being young.
Yeah. No, that's a really good
and so let's not think that the worst thing that can happen is you can get old. I mean, aren't we all wanting to maintain our health, hopefully, to get into the later years? What, for the purpose of just entering a dreary time of our life? So anyway, I think in my field, which is geropsychology, in which I have been involved with colleagues about building what we call foundational knowledge competency about aging. We start with attitudes initially, and then facts. And old age is not just being a used up machine. Old age is a beautiful and complex process which reflects many, many strands. And the physical aging is one of them. Yes, it's true. Your body is wearing out. But it's so much more than that. And so, you know, the book that you had mentioned, actually, I'd asked you to mention, reviews that. And so it was my attempt to try to do the basics for people who don't know about aging. And I'm sorry to go on here, but here's the deal. With 10,000 baby boomers turning 65 every day, with 20% of the population in a few years being 65 and older, if you didn't think you were going to see older adults in clinical practice, unless you're in pediatrics, you're going to see older adults. So better to know something about it, and especially be vigilant about the negative attitudes that you hold about aging, including your own aging.
Yeah, that's really, really good advice. We also have someone who is asking if you know any studies that perhaps show if depression in someone living with dementia diminishes as they advance into different stages of dementia.
I didn't quite understand that question. Studies that show
that if someone has depression in perhaps the first stage of Alzheimer's disease or other types of dementia, does this diminish as you go from
Oh, you mean do the
early
person
to
get
late?
less depressed over time? I don't,
Or
that's a good question. I'm not sure, but we certainly know that over the course of a dementia, the things are highly variable. One observation is at the beginning, you may have more agitation and upset when people are more aware of their limitations, than later on where you may be less cognizant of that. So I don't know whether depression is less prevalent among people with more advanced dementia or not. I don't know.
Mm-hmm. Okay. And then we also have someone who asked, what are some ways to deal with verbal or physically aggressive behavior?
Well, Linda Terry and her colleagues in the ABCs of dementia care would say, first of all, you want to observe what a trigger may be for that.
Mm-hmm.
And it may seem to come out of nowhere, but it's possible that there's a trigger that's not so obvious. And I don't know. What do I hear from nursing home aides? If you want to take somebody and say, okay, it's time for shower time, and you take the person and sort of roughly move them to the bathroom, they may hit you.
Mm-hmm.
But the wisest nursing aides will say, you start out, you sit down, you speak in a pleasant voice, you check in with them emotionally, and then you raise the topic in a way, and begin and so there, I'm not minimizing how complicated it can be, but there can be triggers, and they're variable from one person to another. But I think that what has been found is it's good to look at the ABCs. What is activating the problem behavior? How did you respond, and with what effect?
Mm-hmm.
You know, so
Definitely.
that can be helpful to think that through.
Mm-hmm. And I'm just going through, we have so many excellent questions. I'm going to try and get to as many of these as we can before this ends. But thank you all for these really, really wonderful questions. We have someone who mentioned that depression medications all come with strong warnings about giving it to individuals with dementia. And this person was wondering if you'd be able to comment on the safety of these medications for dementia patients.
I don't prescribe medications, but I can just say that the warnings, most significant warnings are for what we call antipsychotic medications.
Mm-hmm.
And in fact, some of the antipsychotic medications are known to increase risk for death in people with dementia.
Mm-hmm.
And so they have to, if they're going to be prescribed, they have to be prescribed with great care. With regards to the antidepressant medications, I haven't heard that, but it's quite possible is someone with dementia, if their brain is increasingly being compromised, that they may have reactions to standard antidepressants that other people might not.
Mm-hmm.
So that's all the more reason to have a geriatric psychiatrist on the scene. There are not that many of them. In fact, there are not that many people who specialize in aging. But you'd want somebody who would be knowledgeable about that, or general doctor who would be willing to consult with somebody who has that expertise.
Mm-hmm. Yeah, great. I love this question. I think that in the time that we live in now, with so much stuff being virtual, I think this is such a great question. Is Zoom or something similar to that, like FaceTime or a phone call, easier for someone with dementia to process and follow a conversation?
It probably depends upon what level of difficulties they're having. And it
Mm-hmm.
might be worth experimenting. I've had people with cognitive problems who use Zoom just fine, and
Mm-hmm.
others get totally confused. They think the person is in the room with them when they're not,
Mm-hmm.
and think it's rude when somebody logs off that they walked away without saying goodbye, thinking
Mm-hmm.
the person should be there. So I would say find out what works, it depends. And for some people, the phone may be the best option, but don't assume just because somebody has cognitive problems they can't do it. But try it out.
Mm-hmm. Yeah. And someone asked, how do we distinguish normal depression? I'm sorry, how do we distinguish that normal sadness has progressed beyond to depression?
Well, remember that Cornell Depression and Dementia scale
Mhm.
has their criteria for that, but I would just say one simple thing is everybody has good days and bad days. I do too.
Mhm.
And
Mhm.
so if a person who just seems to have one bad day after another, that is, they're sad, they don't want to get out of bed, they don't want to do anything, they're talking more negatively, then you would begin to wonder whether it's more than just the average up and down.
Mhm. Mhm. Okay, yeah, sorry. I'm just going through, there's so many questions. Someone mentioned that they found during the pandemic many older people who did not show signs of dementia before the pandemic began to show signs of dementia. They reported having difficulty with tasks that they previously were able to perform independently. Perhaps it is because of a lack of support that was available before the pandemic. So if you have maybe any comments on that. And
I'm sorry. Go ahead.
this person also mentioned that you are excellent and was wondering if you were taking any new patients.
Oh, thank you for the vote of confidence. If you receive your primary care in one of the 3 clinics sponsored by our department, which is there's the Geriatrics and Palliative Medicine Department at Mount Sinai, people will refer to me. Otherwise, I don't. But thank you for those nice comments. I appreciate it.
Yeah, we're getting a lot of thank yous and
Oh,
excellent.
that's great. Well, good. That's meaningful to me. Since I
Mhm.
can't see any of you out there, I love in-person audiences. You can actually see people's faces.
Yeah.
So I would just say I have noticed that among people who have been socially isolated during the course of the pandemic, that some people lose abilities,
Mhm.
and I think it's consistent with what we know, that one of the protective factors for dementia is being socially engaged, intellectually engaged, um, uh, and um, and taking care of your health. It's use it or lose it is not really entirely true, but there are elements of it that are true. And if you have
Mhm.
somebody who has cognitive problems and they're doing less, it's not surprising to me that they would begin to lose abilities at a rate that is faster than they would have normally lost them.
Mhm. Mhm.
So that's my thought.
Mhm. Mhm. So it appears we're almost done with this webinar. Sadly, I really want to thank you all for all these really great questions. Unfortunately, we're not able to get to all of them. However, I'm going to be sending you all an email after this. So please feel free to send us any questions that you might have, anything that we can do to help you with. But first, I really just want to thank you so much, Dr. Hinrichsen, for your thoughtfulness in creating this presentation and really just taking the time to speak with us. This is just so valuable. I learned a lot. I hope you all took a lot from this as well. So I just really want to thank you so much for the work that you do and for spending an hour hanging out with us.
Thank you. Thanks for all your good work, and to all the people in the audience.
Yes, thank you. And thank you to everyone who attended today's webinar and taking the time to learn with us. It was so exciting to see all of your names pop up on this screen. So I was very, very happy to see that. And we're really excited and looking forward to our next Care Connections webinar on March 10th from 1 to 2 p.m. Eastern. So I really hope to see you all there for our next one. And really just thank you all again so much for coming.
Bye-bye. Thanks.